Good evening, everybody. Now we have finished the type 1 hypersensitivity reactions, which is, we called it, if you remember, the anaphylactic type or the IgE mediated type, and all the diseases that are involved, including the immune mechanisms. And the so important to remember that it is the IgE mediated immune response, here the cells that are involved are the mast cells, and you have to know what are the immune mediators that are produced from the mast cells, and how the mast cells, they do have an IgE Fc receptor that binds to the IgE Fc part, and then when the allergen binds to the Fab region of the IgE, a cross-linking is going to take place, and then degranulation will happen, and those immune or what we call the inflammatory mediators are responsible for all the signs and symptoms of the allergy or the hypersensitivity reaction. Today we will be talking about type 2 and then type 3 and then type 4 hypersensitivity reaction. And in type 2, as you know, here we are talking about the IgG antibody or the IgM antibody here, and those usually they are going to bind to antigens on the surface of cells. If it is a red blood cell, then immune hemolysis then it's going to take place. If it is a solid tissue, then that cell is going to be destroyed by the complement binding here, and then destruction of cells. And when complement is activated, usually it's going to call upon PMNs to come into the area, so more of inflammatory cells, PMNs, are going to come into the area. So in type 2, 3, and 4, you have to know then the name of the disease that is involved, and the immune mechanisms, which are IgG or IgM antibody, and then what is the immune mechanism that is involved. So in type 2, it's IgG or IgM, very important to know, and then complement will be activated, and then cells are going to be destroyed. So here it says damage. If the cell is a red blood cell, then immune hemolysis is going to take place. If it is if the antibody binds to a solid tissue, then that tissue is going to be destroyed. So you have to know the names of the diseases and the immune mechanisms that are involved, and how we make the diagnosis. So we will see in most of these diseases, type 2 and type 3, where antibodies are involved, usually the kidney is going to be affected. And for example, this is an immunofluorescence type of a testing showing here the reaction against the basement membrane of the kidney in general. So it is so important in these types of hypersensitivity reactions, type 2 and type 3, to know if the kidneys are involved or not. So in type 3, for example, the immune complexes usually they precipitate on the basement membrane of the kidney, and you can detect those with an immunofluorescent type of a technique. So in some of those diseases that we are going to talk about in type 2, it's not necessary that the binding of the antibody to its receptor on cell will lead to damage. Sometimes this antibody has a stimulatory type of a reaction. Like in this disease, we call it Graves' disease, where the antibodies are going to bind to the thyroid gland cells, and the binding here they will act as a hormone like T3 or T4, stimulating the thyroid gland to produce thyroxine and thyrotoxicosis. So in this condition, for example, a 62-year-old woman complains of increasing anxiety and restlessness. Her doctor notices that she has an enlarged thyroid gland and a fast pulse, both signs of hyperthyroidism. We call it thyrotoxicosis in general. She also has exophthalmos, and bulging of the eyes. We'll see it in just a second. And the blood test shows that her thyroid gland is overactive. Lots of hormones are secreted, and she has autoantibodies to thyroid gland, peroxidase to thyroid peroxidase enzyme, and the thyroid stimulating hormone here receptor. So when they bind to the receptor, they act as a hormone. All diagnostic here, or diagnosis of what we call Graves' disease. So when we talk about Graves' disease, it's thyrotoxicosis, where the antibodies have a stimulatory effect to the thyroid gland. She is treated with anti-thyroid drugs, and her symptoms improve, and when they decrease the anti-thyroid drugs, then her symptoms will lower down. So then in Graves' disease, as you see, the antibodies that are produced against the thyroid gland, they will bind into the thyroid stimulating hormone receptor. So the thyroid stimulating antithyroid antibody, binding thyroid stimulating hormone receptor, and the antibody binds to the receptor and stimulates here thyroxine secretion. So when the antibody binds to the receptor, it's going to stimulate the thyroid gland to produce more of thyroxine and more of that particular hormone. This is what we mean by exophthalmos, and this is pathognomonic for thyrotoxicosis, and oversecretion of the thyroid gland, where here certain fat, it's going to deposit underneath the sclera or the eyeball, pushing the eye outside. So we call this exophthalmos. So this is pathognomonic of Graves' disease and finding. So another classical example of type 2 hypersensitivity reaction is the hemolytic disease of the newborn. when an Rh negative mother carries an Rh positive baby. So during her first delivery, she will be exposed to the Rh positive red blood cells, and then she will be sensitized. So in the second pregnancy, those antibodies against the Rh positive red blood cells, they will pass from the mother to the baby and sensitize the red blood cells of the baby, as you can see here. And so the antibodies, they are going to bind to the Rh positive baby here, and complement will be activated, and so immune hemolysis will take place. And so this is what we call here hemolytic disease of the newborn. Remember that when a mother, which is Rh negative, carries an Rh positive baby and gets sensitized the first time. So the second time when she gets pregnant, here antibodies goes into the baby and cause destruction to the baby's red blood cells. Hemolytic disease of the newborn. Rh positive baby, and the mother is Rh negative. So here we make the diagnosis of hemolytic disease of the newborn with a test. We call it the Coombs test. And here we detect the antibodies that are present on the Rh positive red blood cells. So for example, if here this is like a negative control, when the red blood cells they are not sensitized, for example, then you see separated red blood cells normally, because there is no binding of antibodies to red blood cells in order to clump. But if you have here the baby is sensitized with the antibodies against the Rh antigen, so the red blood cells of the baby are going to be sensitized. So when you add the Coombs reagent, which is anti-globulin reagent, and antibodies against antibodies, so you can see clumping is going to take place. And this is how you see the clumping here compared to the negative control, here where there's no clumping. And so this is a positive direct Coombs test. And you can see if the mother is having antibodies, for example, not just the baby. Here we call that the indirect Coombs test, and you add the mother's serum into Rh positive red blood cells and sensitize those in vitro, and then you add the anti-globulin reagent. We call that the indirect Coombs test. So I want you to remember the Coombs test, direct one. Immediately we put the Coombs reagent, which is the anti-globulin antibody on the baby's red blood cells, immediately cause clumping. Versus the indirect Coombs, where you do the sensitization first in vitro. So those patients, when the mother gives her first baby, which is usually will deliver normally, and if she might be getting exposed to Rh positive red blood cells, so the minute that she is born, we give her an injection with anti-D antibodies, which we call it the ROGAM. And by doing that, we will suppress her ability to produce antibodies against the Rh positive cells. And also we will destroy any Rh positive red blood cells that could have leaked into the baby. So although then fetal blood cells have leaked into the maternal circulation, these can be here destroyed by anti-D injections, and we get rid of all of the red blood cells that could be sensitized. So here in type 3 hypersensitivity reaction, we are talking about a soluble antigen and soluble antibody. They form immune complexes, and those antigens, they could come from an infection, and we will talk about those in just a second, or they could come from the environment, like some mold spores, for example, and we inhale them, or an auto antigen, for example, like an SLE, systemic lupus erythematosus, where the antigen is simply a DNA and the antibody is anti-DNA antibodies. They form immune complexes. So the antigen could come then from an infection, or from the environment, or from an auto antigens of the body and autoimmune disease. So then the complement is going to be activated, and in most of the time, it depends on the amount, a clearance of the immune complexes is going to take place. So when the immune complexes develop, either they will be cleared out by the complement, or they could be localized in one area, like giving an injection, for example, of a vaccine, and if the patient is immunized already and have antibody, then immune complexes will develop at the site of the injection, and we call that an Arthas type of a reaction if it is localized, or in what we call farmer's lung syndrome, for example. The same thing here. The spores of certain fungi, if they are inhaled and the patient is sensitized, they will develop immune complexes in the lungs, and could lead to destruction of the alveoli under the effect of these immune complexes that they will develop inside the alveoli. Or they could be they develop systemically, here disseminating all over the body, and these immune complexes, wherever they go, they activate complement, and PMNs, they will come into the area and cause destruction. So remember then, systemic lupus erythematosus, it's a generalized immune complex disease, where the immune complexes are present everywhere, or it could be localized, and this is the one that we call Arthas type of a reaction. So in the type 3 hypersensitivity reaction, where we have an immune complex disease, usually the severity of the reaction, it depends on the amount of immune complexes that will develop, and the complexity, or how much immune complexes are present, it depends on the amount of antibody as a volume, as well as the amount of the antigen. So when they are here optimal, their percentage, we call that in precipitation the zone of equivalence, or the zone of optimal proportion, where large amount of immune complexes are going to take place. So when you have a very high antibody level, or very high of an antigen, in those extremes, usually the amount of immune complexes are not that high. But when they are in optimal proportion, as you can see here, in 2 and in 4, then the amount of immune complexes that develop are so high, and this is going to activate complement and calls upon PMNs to come into the area, and inflammation is going to be here established in relationship to the presence of those immune complexes, and wherever those are located, either locally in Arthas reaction, or systemically, like an SLE, systemic lupus erythematosus. So the key here is the complement activation, then and the call upon neutrophils to come into the area. So in general, in type 2 and 3, as well as type 4 hypersensitivity reactions, it takes much longer time compared to type 1 hypersensitivity reaction, usually in hours, whilst in type 1, for example, usually in seconds to minutes afterwards. So here in farmer's lung syndrome, usually it takes 2 to 3 hours to take place. The patient usually inhales here the spores of certain fungi, and then the patient becomes sensitized to the antigens of those spores. So the second time he or she get exposed to these spores, the immune complexes will develop in the alveoli, and then inflammation and allergic types of pneumonia is going to take place. Very important to remember that the antibody here is usually an IgG type. Could be IgM, but mainly the antibody that's responsible for the precipitation type of reaction is the IgG type. So it's so important to differentiate this farmer's lung syndrome from the IgE mediated, which is the antibody is IgE, and it's much faster compared to that of type 2 or type 3. So as you can see here, for example, in type 2, here when the antibody is going to develop against the alveoli here, and then complement will be activated. So here this patient has precipitating IgG antibodies against the mold proteins, and then complement will be activated. That's going to call upon PMNs to the area and destruction to the alveoli, as you can see. So farmer's lung syndrome then is an immune complex disease where the patient here allergies are against here the mold spores here, and the patient gets sensitized against those. So in type 3 hypersensitivity type of a reaction where immune complexes could develop, as we said, it is either localized, like in what we call the Arthur's type of a reaction, or it could be systemic, like in SLE, systemic lupus erythematosus. So in the localized type, and this is very common when a patient takes a second injection for a vaccine, and if the patient is already sensitized, so an antigen antibody reaction the second time it's going to take place, and immune complexes will develop locally, and these immune complexes will fix complement or activate complement, and will call upon neutrophils to come into the area. So you will have a localized inflammation here at the site of injection. And as I said, it's extremely important to differentiate this from the type 1 hypersensitivity reaction, where in type 1 it is so immediate, within seconds to minutes the reaction will take place, while in type 2 or type 3 usually it's much longer. It takes hours rather than minutes. So it's important to differentiate because how you are going to respond to this type of a reaction, whether it is type 1 or type 2 and 3, is completely different. I want you always to remember that type 1 is mediated by IgE antibody who has receptor on mast cells, the Fc portion on mast cells, and then degranulation of mast cells will take place, and the inflammation that will come is related to mast cell then degranulation, while type 2 and type 3, it's just an IgG or IgM antibodies, and then complement will be activated. And this is going to take, as I said, much longer time than type 1 hypersensitivity reaction. So this is what I was talking about when the patient who is sensitized takes an injection, and the localized immune complexes will develop in the area showing the inflammation. And then will explain what I was talking about and how these antibodies are going to develop, and then complement will be activated, and then as a result of that, then localized inflammation will take place. And remember that it will take hours here for the Arthas reaction to take place, 2 to 3 hours compared to minutes, as I said with the type 1. And the types of cells and antibodies are completely different from those of the anaphylactic type. And as I said, here this is an immunofluorescent technique showing the deposition of the immune complexes in the kidneys, and you can detect those with an immunofluorescent type of technique showing the immune complexes deposition on the basement membrane of the kidney. So while in type 1, for example, you don't see any immune complexes at all. It's just the degranulation of mast cells and mast cell here anaphylactoid type, or I mean the chemical mediators that are going to be released by the mast cells. So again, in type 3 hypersensitivity reaction, we could have a local immune complex disease deposition, which is the Arthas reaction. Remember, always vaccination related to that when the patient is already vaccinated. Or, for example, in the SLE here, where in the systemic lupus erythematosus, here the immune complexes, the antigen is usually DNA, and the antibody is anti-DNA, and those immune complexes, they will precipitate in the different tissues of our body, and wherever those they precipitate, complement will be activated. So the detection of the specific amount type of antibody, which is here usually it's an IgG antibody, is extremely important to know in the treatment regimen. So again, this slide again talks about how the immune complexes that they will develop in SLE or the systemic type, they deposit in tissues, and how long immune complexes usually they will be fragmented, and then they will deposit in tissues, and then they will be cleared out of the circulation by binding into the Fc portion of the immunoglobulin, wherever those are located, as you can see, and complement usually will be activated, and then here phagocytosis will be taken care of, and they will be cleared out of the circulation. So in this slide also it will show how the immune complexes that they will deposit in tissues could have a variety of inflammatory type of a reaction, it depends on the type of the immune mechanism that is involved. Here, for example, you can see the anaphylaxis target, for example, of neutrophils on the lesion. And here, when the immune complexes they are fragmented, then here the same thing here, thrombi could develop as part of the reaction that is involved. Immune complexes activate mast cells, and the mast cells here will here responsible for a different type of inflammation. Like platelets are also activated by the immune complexes, and they form here thrombi. So mast cells activation, immune complexes, inflammatory type of a reaction, all of those are sequences of the immune complex type of a disease. This slide shows here the effect of the deposition of the immune complexes on the kidneys in what we call in the development of what we call the nephrotic syndrome, nephrosis, or nephritis, or nephritic syndrome, inflammation like glomerulonephritis, or in the nephrotic syndrome, where the protein just will pass through the kidney. So as you can see here in this slide, it shows you the basement membrane of the kidney and the epithelial cells lining here the basement membrane of the kidney. And when the immune complexes, they deposit over the basement membrane over here, then complement then will be activated, and then PMNs will come into the area that will cause destruction to the basement membrane. And here, when immune complexes form rapidly, for example, there is here damage to the basement membrane, and a cellular infiltrates can be seen in that particular area, while in nephrotic syndrome this is not going to take place, and there is no damage to the basement membrane of the kidney. So the last part of the hypersensitivity reaction, which is the type 4, or what we call the delayed type hypersensitivity reaction. And so from its name, it's a delayed type. Usually it takes 2 to 3 days. The classical example of the delayed type hypersensitivity reaction is the pathogenesis of tuberculosis, or the PPD testing that usually will take 2 to 3 days to develop. So it is so important to know the types of diseases that activates type 4 hypersensitivity reaction, and the consequences that will follow, and what is the mechanism of the tissue damage that will be involved here. So in the delayed type hypersensitivity reaction, then we have so many objectives that you have to know. You have to recall how delayed hypersensitivity reactions they rely on the cytokine network. So it's the cytokines and their functions here that plays a role in the pathogenesis of these types of reaction. Second, here describe the pathogenesis, diagnosis, and treatment of some examples, like in multiple sclerosis, for example, and in rheumatoid arthritis. So those you should know those in details, what's happening, how the delayed type hypersensitivity plays a major role in the pathogenesis of these types of diseases. Describe the benefits and limitations of corticosteroids in delayed here hypersensitivity reactions. We'll see that these types of delayed type hypersensitivity, we use mineralocorticoids, steroids, and for the treatment. So what are the benefits and the side effects of that? Especially we could use those for a longer period of time when we are talking about chronic illnesses. Describe the clinical importance of the cytokine redundancy and here the pleomorphism of anti-inflammatory reactions or fragments, treatments, sorry. The inflammatory treatments. We'll see how sometimes we could use here inflammatory or types of antibodies to suppress the immune system. We will see how these are applied in immunology. And finally, describe how the Gill and Coombs classification of hypersensitivity reactions are used to diagnose and treat a wide range of disorders. So here when we talk about the different types of hypersensitivity, type 1, 2, 3, and 4, this is what we call the Gill and Coombs type of classification. You have to know those every time we talk about any here hypersensitivity type of a reaction and how we use that in order to make a diagnosis and treatment of that particular disease. So in the delayed type hypersensitivity reactions, then the common goals or backgrounds in those types of diseases are the production of cytokines. And so you should know what are these cytokines and their functions. And the most important or the two classical examples of the delayed type hypersensitivity reactions, beside of course tuberculosis here, are the rheumatoid arthritis and multiple sclerosis. So you should know what's the pathogenesis that is involved in this delayed type hypersensitivity reactions and here the cytokine networks that plays a role in those types of diseases. Rheumatoid arthritis and multiple sclerosis, and you have to know that those are crippling type of diseases if they are not treated early. So here in delayed type hypersensitivity type of reaction, you should know the classical examples that are involved of the diseases, like in multiple sclerosis and in rheumatoid arthritis. And as I said, those are a crippling types of disease that usually takes longer period of time, and usually this type of reaction minimum will take 2 to 3 days to start seeing the signs and symptoms. Also, you have to know the drugs that we use for treatment is not just the steroids here that we are talking about, but also cytotoxic drugs, and you should know the side effects of both, and especially when we use them for a longer period of time. And here the most common things to remember is the immune suppression and how the patient becomes susceptible here to what we call opportunistic type of infections. And we should know here what are the cytokines that are involved in this delayed type hypersensitivity reactions and how those can be modified here for the treatment. And so important to remember about the reactions to the drugs that are involved in the 4 different types. Also, you have to know here the mechanism of the PPD testing, the purified protein derivative testing, how it is slow, what are the cells that are involved, the T helper 1 cells, and then the T helper for the interleukin 1, for example, produce, and interleukin 6. Also, that's not just the helper 1, but also we are talking about the other cells that are involved, and you should know these cells in general. And also, you have to know about the hard to clear infections. These are chronic types of infections like tuberculosis and the hepatitis B virus. Here it's so important to know. And also the types of lesions that are involved, we call them the granuloma, and you should know what are the components of the granuloma, and within those we could develop what we call caseation necrosis here that is involved, and what is the mechanism of the caseation necrosis. Also, other diseases, delayed type hypersensitivity, like the contact dermatitis, and you should know what are the agents that are involved in this type of a reaction, where we have heavy metals, nickel, chrome, for example, and the effect of those on the skin, and what's the mechanism that's going to be involved. So contact dermatitis, and how these agents, they are haptens, small molecular weight molecules that they require protein carriers in order to do the inflammation. Certain types of plants like poison ivy, for example, it's a delayed type hypersensitivity reaction. And then we need to talk about the self antigens here, like the insulin dependent diabetes mellitus, and here the immune mechanisms involved that will lead to the destruction of the beta Langerhans cells of the pancreas. So here, when we talk about the delayed type hypersensitivity reaction and the T helper cells that are involved, which is usually the T helper 1, the type of cytokines that are produced. So the T cells usually stimulate macrophages. So the key cell in the delayed type hypersensitivity that needs to be activated is the macrophage. And those, they will be activated by secreted interferon gamma. And both cells, they secrete a tumor necrosis factor. This is another here mediator that plays a role in the delayed type hypersensitivity reaction, which has a wide range of targets in our body. And finally, the activation of the macrophages, here they stimulate T cells by secreting interleukin 12. So you have to know the interleukins that are involved: interleukin 1, interleukin 6, for example, interleukin 12, the tumor necrosis factor that plays a role in such type of a reaction. So in rheumatoid arthritis, you will see usually it affects adults over 50 years of age. That started with the small joints, the interphalangeal types of joints. And then finally here leads to destruction of these small joints. And also the immune pathology that is involved through the cytokines that are going to be produced. Tumor necrosis factor plays a major role in the pathogenesis, and of course activation of the macrophages that will lead to destruction of these types of joints. Very important point also to remember about the CCP, or what we call the cyclic citrullinated peptide, CCP. And we see that it's almost pathognomonic for rheumatoid arthritis. And of course, the rheumatoid factor. And the rheumatoid factor is just simply an IgM antibody directed against IgG. So these immune complexes that will develop is going to destroy the joints in particular. So it's extremely important then to know the pathogenesis and the destruction of the joints that are involved, and the very important, the cytokines that are involved. Tumor necrosis factor plays a major role, and when you use monoclonal antibodies against the tumor necrosis factor, you will see that those patients they will improve tremendously. So in rheumatoid arthritis, then we will see how we have many factors that are involved in the on the pathogenesis. For example, the infection theory, like the Porphyromonas, for example, infections could lead to the CCP. Also, the cytokines that are involved. It is so important to know about those and their mechanisms, and also the many other factors that are not known. You have to know these virulent factors, or the damaging factors related to the cytokines that are produced. And the antibodies, for example, in the treatment against the citrullinated proteins, they play a major role in the treatment. Some genetic factors that could be involved, like HLA, for example, types. The HLA-DR4, they are more susceptible. Also some other factors that are not known till now also. But the T helper 1 cells and the cytokines that they produce, they play the major role. T helper 1 and T helper 17 cells, they play a major role in that. At the beginning, maybe the patient would be asymptomatic, and then they would start having joint pain, and then inflamed joints, and then the joints could be destroyed by the activated macrophages that are involved. So I want you to remember these then immune mechanisms, the CCP, the citrullinated proteins that are involved, and the other cytokines that they play a major role in the destruction. The T cells that are involved, T helper 1 and T helper 17, for example, role. Very, very important. And of course, the development of what we call the rheumatoid factor here, which is not specific I want you to know it is an rheumatoid factor, it's an antibody IgM against IgG that will form immune complexes as well. But it's important as a finding in collecting data here for the diagnosis of rheumatoid arthritis. So it is so important to understand the pathogenesis of rheumatoid arthritis and what's the mechanism of destruction of the bone. So you can see here how neutrophils, to start with, they migrate into the synovium under the influence of the tumor necrosis factor. So the tumor necrosis factor is the triggering here cytokine in the rheumatoid arthritis. Remember, the monoclonal antibodies that we use against tumor necrosis factor helps in the treatment a lot. And then some other cytokines, such as, for example, interleukin 6, as we said, leaves the joints and initiate an acute phase type of a reaction. Then the B cells in the synovium are usually stimulated to secrete here an auto antibodies. We call them the rheumatoid factors. So tumor necrosis factor then stimulate then the macrophages to secrete an enzyme which we call it the metalloproteinase, which breaks down the matrix proteins. And the most important point to remember that the cells that are involved in all of this problem are the osteoclasts. Those they are specialized macrophages that erode the bone when stimulated by the tumor necrosis factor. So the key then cytokine is the tumor necrosis factor in rheumatoid arthritis, as I said, which is the one that stimulates the osteoclast that is going to corrode the bone and makes destruction to the bone. So if you get rid of the tumor necrosis factor at the beginning, then this is a critical point in the treatment regimen. So again, then in summary, delayed type hypersensitivity, the delayed type hypersensitivity driven by the here T helper 1 cells cytokines that are produced here. So those they will act on the macrophages, where macrophages they initiate the signal and then act as an antigen presenting cells. They present the antigen to the T helper cells, and then the T cells and the macrophages stimulates each other by the cytokine network. Tumor necrosis factor is the key, as I said, here cytokine involved, responsible for most of the damages. And if you get rid of the tumor necrosis factor from the beginning, then a dramatic improvement is going to take place. What about genetic factors? Yes, there is an HLA alleles association, as in insulin-dependent diabetes mellitus, for example, as well as in celiac disease. So all of those are delayed type hypersensitivity reaction type 4 insulin-dependent diabetes mellitus, as well as celiac diseases. There is an HLA association with those types of illnesses. So again, rheumatoid arthritis, multiple sclerosis, celiac disease, and insulin-dependent diabetes mellitus are the classical examples of type 4 delayed type hypersensitivity reaction. Rheumatoid arthritis here affecting, of course, synovial T cell, and macrophages play a role in there, and leads to thickening of the synovial membrane. And of course, the macrophages or osteoclasts that are going to destroy the bone associated with that. Antigens is the citrullinated protein, the CCP, more than 100 here cytokines that are involved in the synovium. But remember that T helper 1 and T helper 17 are the ones that they play a role in this regard. Tumor necrosis factor, interleukin 1, interleukin 6, we talked about those before. Tumor necrosis factor then activates the endothelium up, forming adhesions, and then PMNs, polymorphonuclear leukocytes, here are going to be produced. The neutrophils get activated to produce what we call the metalloproteinase enzyme, which here digests the matrix proteins and inflicting injury to the joint. Then the osteoclasts, the major cell that is responsible for the damage, will be activated and then will be responsible for the erosions that is going to take place in the bone. So cytokines activated, they activated cytokines, the B cells, here to produce the rheumatoid factor, which is an antibody, IgM against IgG, and it is not specific for rheumatoid activation, or so here the rheumatoid factor then is one of the factors that are needed for the diagnosis. So it's not specific for rheumatoid arthritis, but it is it shows as an element in the pathogenesis of this disease. What about multiple sclerosis? The same thing, multiple sclerosis, a delayed type hypersensitivity reaction against the myelin basic proteins in the neuronal cells. That's going to lead to destruction of the neuronal cells. First of all, it will be irreversible, and then it becomes permanently irreversible and destruction to the here neuronal cells. So as you can see, those are the myelin sheath that usually protects the neuronal cells, formed of myelin basic proteins. Antibodies against that is going to develop, and complement will be activated, so and called upon macrophages to come into the area that will lead to damage of the neuronal cells. As I said, starts as to be reversible, and then in the relapse that will develop becomes irreversible, and permanent damage to neuronal cells are going to take place. So the activated macrophages then are the ones that are responsible for the destruction of those neuronal cells in response to a reaction against the myelin basic protein that protects the neuronal cells at the beginning. So just summary points for the multiple sclerosis then. It's a disabling disease within 5 years of onset. And within 5 years, usually the patient will be disabled or crippled in general. The main pathology is usually demyelination will take place, forming plaques of the CNS or the neuronal cells. Sorry. Here, some environmental factors could play a role more than genetics. So environmental factors, they play a role more than genetics. So genetics and environmental factor, but environmental factors much more. Following infection, as for example, measles virus, Epstein-Barr virus, those they play a major role in the development of an immune response that will react against the myelin-basic proteins. So infection then can precipitate relapse. Genetics, here the concordance rate and association, direct association with the genetic is around 30%. So environmental factor is usually 70%. Inflammation leads then to neuronal loss and destruction, and it is to start with a reversible disabilities يعني بصير في relapse due to axonal loss. It will be then permanent damage and becomes the condition irreversible. So in those types of patients, multiple sclerosis, the demyelination that's going to take place, how we are going to treat? First, avoid being exposed to the environmental factors that we have mentioned. The environmental antigens and the infections, measles and so on, the contact dermatitis could be related to here nickel and chrome, here in involvement. Celiac disease, it's usually a gluten enteropathy associated with diarrhea to the GI tract. Here, anti-endomysial antibodies, those antibodies, they will arise indirectly with the celiac disease, and the endomysium is the cement usually between the cells, and this is an indirectly proportional to the gluten enteropathies. So the treatment, we use the anti-inflammatory and immune suppressive medication, since it is a chronic inflammation. And we use the non-steroidal anti-inflammatory drugs like aspirin, for example, ibuprofen, or indomethacin. And then finally, we could use the corticosteroids that has lots of side effects, but can be used for the treatment. And because the tumor necrosis factor, the one that plays a major role in this disease, then we could block the tumor necrosis factor by usually using mouse monoclonal antibodies, or here a chimeric antibodies, like using mouse, from mouse humans combination, mouse plus human fragments. We could use both here for treatment. And we could use the recombinant tumor necrosis factor receptors, for example, to get rid of the tumor necrosis factor here. So when we do that, we could improve the patient's condition dramatically. So we have to watch for the side effects of these here immune suppressive drugs, like tuberculosis, for example. And we start with a disease and could end up with another disease. And we could have what we call a redundancy of the cytokines. We are here afraid of this redundancy. More than one a blockage is needed. Yani just more than one cytokine that is involved, and you need more than one blockage. So it becomes so difficult sometimes to get rid of all of these cytokines at once. And also these recombinant drugs, they are very expensive. The tumor or the we could use a tumor necrosis factor beta, usually or interferon beta reduces the T cell here migration across the blood-brain barrier, so we could improve the patient's condition. The acute phase here receptors sometimes or responses, acute phase responses, here we could use that for diagnosis. And we could use recombinant here more acceptable here, for example, because they are not they might not induce an immune response. So if you do have any foreign proteins in the recombinant medications that you use, then you are exposing the patient to foreign proteins and more immune response against those, as we will see in just a second. So immune suppressive drugs then we could use, and those they will should or could suppress our immune response. And they are effective then the antigen cannot, if the antigen cannot be avoided, then we can use those immune suppressive drugs. So we have to watch for the side effects of the infections, and the because it's a lifelong here medications. We are going to use them for a longer period of time, so we will end up here with immune suppression. So the side effects because of the long run could be unacceptable to use those. So these are some of the new trends that we use here in making here factors to get rid of those cytokines against the tumor necrosis factor, for example, making sorry, making, for example, a recombinant here receptors, for example, for the tumor necrosis factor to get rid of those. But if those they do have foreign proteins, then antibodies against the foreign proteins could develop. So as long as you could use human components more, then the less likely an immune response against the foreign proteins could develop. And those then they could get rid of the tumor necrosis factor blockage then taking place. And the most important thing is to use human proteins rather than foreign proteins in the synthesis of these monoclonal antibodies, for example, or any drugs that will take care of those tumor necrosis factor out of our bodies. So then in summary, the hypersensitivity reactions driven here by mixed type of mechanisms, humoral immune response and of course, cell-mediated type of reaction. So cells as well as antibodies, we see those. So the late phase response, for example, of type 1 hypersensitivity reaction, typical, for example, of type 4, where the late response calls upon eosinophils to come into the area. Multiple sclerosis, rheumatoid arthritis, although are type 4, antibodies, they play a role, like, for example, the rheumatoid factor, where they develop an IgM antibody against IgG. And celiac disease, for example, against environmental antigens, but they react here, they react to tissue type, for example, so delayed type hypersensitivity reactions usually cells that are involved, but sometimes antibodies, as we said, they play a major role in the pathogenesis, and detection of these antibodies can help making a diagnosis of those types of diseases. And a classical example is like in celiac disease, where a reaction could occur against an environmental antigen, but here it could reacts to tissue glutaminidase, for example. Here, so detecting that antibody could make the diagnosis of celiac disease. So diagnosis by finding then these here auto antibodies and link them to that type of a disease. So the treatment is usually by the plasmapheresis, just like taking those here antibodies out of the serum. Could work this in a disease called Wegener's granulomatosis, but it doesn't work in rheumatoid arthritis. So this table then will summarize the different here hypersensitivity types of reactions and the tests that we do to make the diagnosis. For example, for type 1 hypersensitivity reaction, the one that we call the anaphylaxis, or that causes anaphylactic shock. And the useful test that we use here for that is the specific IgE antibody here, the detection. And of course, here the skin prick test that we have talked about before, if you remember. In type 2 hypersensitivity reaction, like drug-induced hemolysis, and here we talked about the Coombs test, if you remember. The Coombs test, the direct or the indirect Coombs test for the hemolytic disease of the newborn. For type 3, if it's localized or systemic, in the localized, like Arthur's reaction, and here we use antibody level and immunofluorescence detection as well. And in type 3, the immune complexes here, like in serum sickness, we detect the immune complexes with monoclonal antibodies here. And type 4, like contact dermatitis, for example, like, for example, reaction against antibiotic-containing creams, for example. And we use here the patch test for the skin testing. Here are some of the examples of those type 4 hypersensitivity reaction, like rheumatoid arthritis, and showing the inflamed joints. the carpal joints, interphalangeal joints here, how they are swollen here and inflamed. Like the intercarpal here joints. And usually they have start with pain and then inflammation and then edema associated with that. And when you make an X-ray, you will see destruction of the joints due to the action of the activated osteoclasts that we have talked about. So this is a case of multiple sclerosis of a 22 years old woman complaining of visual impairment in her left eye on 2 occasions when she was 4 years and at 1 year earlier before that. And she had noticed numbness and here tingling in both legs for several weeks. She did not see any doctor about that. On these symptoms, on the other occasions, she became pregnant, and when the woman becomes pregnant, usually she will be immune suppressed, so the symptoms usually will subside. And the symptoms improves. About 2 months ago, she had some unsteadiness in her feet. These symptoms also here improved after 2 weeks or so. And again, she did not seek any medical advice. On examination, she has signs of optical neuritis in her left eye. An MRI here was done showing for a brain scan is performed, which shows many lesions in the white matter of her brain. She diffuse asymmetric here lesions are consistent with patchy inflammation seen in multiple sclerosis. So she was made diagnosed as multiple sclerosis, MS. She also has a lumbar puncture, and examination of her here cerebrospinal fluid, CSF, shows oligoclonal bands, which is almost pathognomonic in multiple sclerosis. Consistent with active here inflammation in the central nervous system. So here, this is the MRI showing the brain and some of the patchy infiltration of the brain. This is so important here to know. On there are patchy lesions you see in this patient MRI brain scan that are consistent with demyelination because of the loss of the myelin that protects the brain, forming patches. Note how these are sited around the lateral ventricle, as you can see here. Right here, bodies in the central of the scan. These give the scan an asymmetrical here appearance. So you can see those patches here of the demyelination that is formed. So this is classical presentation of here multiple sclerosis. So here when you do electrophoresis for the CSF, you see what we call the oligoclonal bands that shows aggregates of immunoglobulins. This is only the CSF, which is pathognomonic, where the lesions are or where the pathology are, while if you do, for example, here electrophoresis for the serum, you will find nothing here. So it's just the CSF that will show the oligoclonal bands, which are pathognomonic of multiple sclerosis. So this table shows some of the hypersensitivity types of diseases, and the names for type 1, like for example anaphylaxis, and the useful tests that we do, like here the IgE antibody level and the PREC test. And then when we talk about type 2, for example, like drug-induced, as we said, immune hemolysis, then we do the Coombs test, so the antiglobulin test. We'll talk about it in the blood banking. And then in the immune complexes, either the localized or the systemic. The localized, the Arthur's reaction, and here we measure the antibody level. While, for example, the serum sickness, here the circulating complexes, serum sickness with monoclonal antibody levels. And then in type 4 hypersensitivity reaction, we do, like for example, the contact dermatitis to the antibiotic, for example, containing cream here, and we do the patch test over the skin to make the diagnosis. This is a sketch showing the antiglobulin test, the direct and the indirect, sorry, the direct immunofluorescence and the indirect immunofluorescence, where you have an antibody that is bound to an antigen, and the antibody here is the one that is having the immunofluorescence, so it will fluoresce if the antibody is fluorescinated. And if you want to detect an antibody, you add a fluorescinated antibody, secondary antibody to the primary antibody here. So secondary antibody or indirect immunofluorescence if we need to detect an antibody, while the direct immunofluorescence if we want to detect an antigen, as simple as that. So the direct and the indirect immunofluorescence techniques, you can use it here to make a diagnosis of any disease where you have antibodies bound to a tissue, like here when we have antibodies that are bound to pancreatic cells in insulin-dependent diabetes mellitus, for example. You can use secondary antibody that is fluorescinated against the primary antibody, and so it will fluoresce, as simple as that. So direct fluorescence or indirect fluorescence for antibody detection. So here, in order to make a diagnosis of celiac disease, for example, the gliadin, anti-gliadin antibodies. It's just simply a competition where we can find indirectly the tissue transglutaminase an antibody level that they will compete here with the gliadin. So the detection of the anti-glutaminase is a reflection of the anti-gliadin, which is we use for the diagnosis of celiac disease. So then the detection of the anti-endomysial antibodies is also an indirect here finding for the celiac disease. So the anti-endomysial antibodies is a reflection that this patient is having a celiac disease.